Our next speaker is Dr. Stephen Hinshaw. And Dr. Hinshaw also serves on AIM Scientific Advisory Board and is one of the leading experts who kind of drives AIM's mission and our investments. And, you know I have always think about ADHD as sort of, when you think about in youth, as sort of a young boy, an adolescent boy with ADHD, and so often we don't think about ADHD in girls. And Dr. Hinshaw is going to share a little bit about that kind of underrepresented population in the study and the effects of ADHD. So Dr. Hinshaw is from the UC Berkeley, and he teaches the developmental course of ADHD and the emphasis on family and peers and all of those factors that play into this disease. So he's also really interested in the stigma. Dr. Insel talked earlier about stigma and using that word. We'll talk about that word a little bit later, but that stigma that kind of clings to this very misunderstood diagnosis. So Dr. Hinshaw, are you on Zoom? There you are. Welcome. Nice to see you. Oh, we have maybe if you check are you muted or?
No, I'm unmuted.
Oh, okay, now we can hear you. Great. Welcome.
Thank you.
Good to see you. Thank you.
Share my screen.
Yes, please do.
Hello, everyone. We're going to go as quickly as humanly possible, but I hope this will be educative about the misunderstood condition of ADHD. Here's a couple of quick disclosures: federal funding, foundation funding, and royalties from a couple of publishers. So we're going to talk for just a few minutes about what ADHD is and is not. Talk a little bit about what underlies ADHD in brains, in people, and in schools and in families. Talk about especially the developmental course of girls with ADHD, a very understudied topic, as was just noted. Touch on treatments and mention this topic of stigma, which is particularly salient for girls and women with ADHD. So ADHD is not just the Tom Sawyer syndrome, fidgety, obstreperous boys. We'll have a photo of this in just a moment. It's not just parents who don't know how to discipline or overburden classrooms. Now, parenting styles and classroom procedures can put a big dent in the impairments of ADHD and help people thrive, but they're not the primary causes. A lot of ridicule. 10 years ago in the press, we learned that ADHD is caused by SpongeBob SquarePants, based on some developmental research, but a kind of sarcastic, almost ridiculing that ADHD is not a real condition. But ADHD, as heritable as it is, which we'll discuss in a moment, isn't just bad genes. The genes that predispose some people to be very focused and others unfocused have been around throughout human history, may be adaptive in some settings and less so in others. So ADHD does involve, for one's age and potentially one's gender, high levels of both inattention disorganization and or hyperactivity impulsivity that cause impairment in the phases and aspects of life that are really important for young people. It's often diagnosed in grade school, sometimes preschool, but girls are often very delayed in getting diagnosed for reasons we'll talk about quite soon. ADHD is misnamed. It's not an inability to pay attention or an attention deficit disorder. Think of hyperfocus. Many people with ADHD, if they get involved in a very engaging activity, can't shut it down. The hours on end of video games, which are of course designed to do that in people, or with a very favored activity. Instead, and we could have a whole talk on this, the biggest effect of ADHD on measures of cognition and working memory and executive functions is not on any one task per se, but regardless of the task, the variability across trials. People with ADHD stay with it and then lapse, and stay with it and then lapse. So ADHD is better conceptualized as a disorder of the regulation of attention and working memory and response inhibition and other executive functions. And if we had time, we'd take you some of the brain mechanisms related to that. It also involves slow development, slower than typical, of intrinsic motivation. That is, getting excited about tasks that aren't usually things that we evolved to learn to do, like learn to read or sit still in classrooms. So external supports and rewards, medications that increase intrinsic motivation are treatments of choice, as we'll discuss at the end. ADHD remains controversial. So I'm going to kick this off, show you 3 slides of medication ads under the doctrine of fair use. I don't work for pharma or consult with pharma, but under fair use, I can show ads to comment on what their messages might be. And the reason we see these ads is for the last 25 years in our country, we've had direct-to-consumer ads. New Zealand and the United States are the only 2 countries on earth that allow that, not just in doctors' journals, but Ladies' Home Journal, late night TV, etc. So here's an ad for Concerta from about 20 years ago. It's regular, good old methylphenidate or Ritalin in a kind of suspension vehicle that squirts it out over 10 to 12 hours. So it's 1 dose a day. It was a big deal when it came out. But here's the stereotype in this ad. White middle-class mother, white middle-class son, just looks like he's got his front teeth in, probably 7 or 8 years of age. And the ad's very provocative. If I give my son ADHD meds, I see the real boy, not those annoying symptoms. So if you think about it, this may be the world's first ADHD-related anti-stigma ad. Medications take away the stigma because you don't see the annoying behaviors, you see the real person inside. Now, whether this is true or not, it's highly enticing and help to spur sales of medications like this. Now, here's another ad from a few years later, and you can see now the market is adults. Adults are by far the fastest growing market share for ADHD medications, especially adult women. And if you have really good eyes, you can read the fine print, and there's citations to the scientific literature that if you have ADHD as an adult, you're about twice as likely to get divorced as somebody else and a third more likely to get major depression. Now, there's a lot of mechanisms going on here, but the quick read of the ad is, get diagnosed with ADHD, take pharmacologic treatment, and you'll stay married and you won't get depressed. So you can see the power of the message. This is part of the controversy, isn't it? And here's our third ad of Shane Victorino, the first Hawaiian American to play Major League Baseball, 2 World Series rings, has had ADHD since childhood. And he came out about 10 years ago when he was still playing with an ad campaign funded by self-help groups and one pharma firm to say, I didn't outgrow my ADHD. That's why I'm telling my story. I know it's cut off. There's a lot of megs in this slide. So that's a powerful message that a great athlete can have ADHD and need treatment. But there's another angle to this, which is that Shane Victorino could not play Major League Baseball and take his ADHD meds unless he had a medical diagnosis and declared that he does have ADHD. It turns out that about twice as many Major League Baseball players have ADHD med dispensations, if you will, compared to the NBA, the NFL, and the NHL. And there's one explanation for this, which is that baseball, sorry, Giants and Dodgers fans out there, baseball is the most boring sport ever invented. You have to be alert for hour after hour, extra innings, and you're sitting on the bench most of the time, but then you've got to be in that extra inning alert for the foul ball or the fly ball coming out your way that you have to stay alert to, or that hanging curve ball. So this is part of the controversy. Are there really twice as many Major League Baseball players with ADHD, or are some of them gaming the system and getting a diagnosis to get a performance enhancing medication? So controversy abounds all over the place with this condition. You need of 9 symptoms of inattention rated by parents and teachers, and of 9 symptoms of hyperactivity and impulsivity. A majority of these, 6 of the 9, at home, at school, in the peer group, starting before the age of 12. They have to cause impairment. Now, this really penalizes girls, whom, as we'll see, may compensate and cope during grade school, but then with middle school, high school, post-secondary education, childbirth, all of these developmental challenges can elicit ADHD later in life, even though it's been present before. Can you get ADHD one day in adulthood? Probably not. It's a big controversial area that we probably don't have time to cover. So thorough assessments are not done in a general pediatrician's or general practitioner's office in 12 or 15 minutes. Long questionnaires, an interview about developmental history, trauma, other conditions, comorbidities. You need rating scales that are well normed from parents and teachers. A school observation is enormously helpful. Some tests of attention are helpful, but they're not totally diagnostic because many people with ADHD, one-on-one in a clinic or lab, especially with an adult sitting nearby, may be able to focus attention for a while, but not in the distracting environment of a classroom. These short, quick and dirty evaluations have led in the United States and Israel to about twice the rates of child ADHD, at least diagnosed ADHD, compared to the rest of the world, again, fueling the controversy. Does ADHD exist alone? Not usually. In a big treatment study that I'll mention near the end of the talk, almost 600 kids in the US and Canada, boys and girls, first, second, and third grade, carefully diagnosed ADHD. Only a third of them had no other diagnostic condition: oppositional defiant disorder, tic disorders, Tourette, depression, anxiety, conduct disorders, quite common. And those need their own evaluation and often separate treatments or related treatments. Richard Scheffler and I, health economist at Berkeley, wrote a big book on this topic a few years ago, covering everything from genes to national policy on educational performance, which we know is a driver of overdiagnosis of ADHD, especially in boys. So, despite the controversy, ADHD is quite costly to our economy, not just for the direct costs of treatment, but for juvenile justice, special ed, substance use treatment for kids, job loss, unemployment compensation, workers' comp for adults. Other kids don't tend to like kids with ADHD because they're the ones who blow out the birthday candles at the birthday party, but it wasn't their birthday, it was their friends. I've seen this happen with my own eyes. Families, except for the genes they pass along, are usually not the primary causes, but they need to be involved in treatment. Accidental injury rates are very high for young people and older people with ADHD. And as we'll hear, so are the devastating behaviors related to non-suicidal self-injury and frank suicide attempts. The DSM is our American Psychiatric Association's diagnostic manual. Dr. Insel and his colleagues 12 years ago now put in place the RDoC, the research domain criteria, as a much more dimensionalized way of figuring out underlying mechanisms. We also know that for boys and girls with ADHD, the cortex, the bark, the outer layer where the cell bodies are, is delayed in development for many, many kids with ADHD by up to 3 to 4 years. The typical age at which the prefrontal cortex reaches its maximum thickness before pruning again is about 6.5. For kids with ADHD, it's 9.5 to 10. Fascinating research going on at the National Institutes of Health and elsewhere on underlying brain mechanisms triggering this neural immaturity, which can lead to the behavioral immaturity so many kids with ADHD display. Two fancy terms: impress your friends. An outcome like ADHD may be, in some cases, part of a family where many relatives have the condition. In other cases, the kid was raised in a horrifically deprivation-laden Eastern European orphanage. And in another case, there might have been seizures or head injury. There's multiple roads that lead to Rome. Everybody with a diagnosis of ADHD didn't necessarily walk the same path. Similarly, if you have ADHD, many times there can be impairments as you get older, as we'll talk about, especially for girls. Resilience can emerge, strengths can emerge with a really well-developed treatment plan. So there are a lot of words on this slide. The heritability, the genetic liability for ADHD, meaning why do some people have this condition or high symptom levels and others don't? Is it mainly because of genes that are different between people or environments? It's mainly genes, it's 80% genes. Bipolar disorder is about 85% heritable, autism spectrum about 90% heritable. These are the three most genetically loaded, if you want to call it that, child and adolescent neurodevelopmental conditions. Even so, don't give up the ship and say, well, it's mainly genes. There's nothing we can do about it. Many conditions that are even more heritable than ADHD, even single gene rare disorders, can be helped by improving nutritional environments, by improving classroom environments, and especially family climate. Other causal factors, being born at low birth weight, maternal drinking during pregnancy, fetal alcohol effects, sort of full fetal alcohol syndrome. Parenting is important for long-term course, even if it's not the primary cause. Environmental toxins, lead, phthalates, lots of new research on many risk factors that can end up in an individual's contracting ADHD. Why have we ignored girls for so long? Here's a quick top 5 list, no time for a top 10. This isn't the case just for ADHD. This isn't the case for coronary artery disease. This is the case even in basic research on animal species with nothing to do with health or mental health in animals. Most studies that rely on only single gender, single sex in animal research have male animals only. So this is a long-standing trend that we're trying to reverse at the NIH and in universities. Fourth, if you think that ADHD, as I learned in grad school a number of decades ago, doesn't exist in girls, then nobody will study them and no one will think that they deserve diagnosis and treatment, and it's a vicious cycle. Third, what did ADHD used to be called? Hyperkinesis, hyperactivity. The symptom list recognized the male symptoms of running around a room or acting as if driven by a motor, a classic item from the early Connor scales, not the inattentiveness and lack of organization and executive functions that characterize actually more girls. It's more characteristic of girls with ADHD than it is of boys. Second, even teachers have a built-in bias that they don't know about. If you observe kids in a classroom and objectively count their behaviors, boys have more hyperactivity and impulsivity than girls, but they're pretty equal in inattention. But the teachers rating the same kids the same days the observations are going on think that boys are higher on both, so the boys are going to get overdiagnosed, over-referred. And as I mentioned, here's the number 1 on our top 5 list. Girls typically are more empathic from an early age than boys, more concerned with achievement, better language abilities early in development, if they and their families are helping to compensate, often at the cost of a lot of stress, perfectionism and anxiety. You might not notice until all heck breaks loose in middle school or high school, or then the structure of the teen years goes into the transitional ages. So girls may be hidden because of their strong efforts and their family's efforts to kind of keep it going until it gets too late. In reality, around the world, there's about 2.5 boys for every girl with ADHD. I don't think this will ever get to 1-to-1, even with better diagnosis, because boys have more autism spectrum, ADHD, Tourette's, early onset conduct disorder. The first 10 years of life are the risk period for boys to show a whole range of neurodevelopmental conditions. Girls during the teen years, in terms of internalizing depression, anxiety, self-harm, shoot ahead of boys, which would be a whole other talk. Girls with ADHD, as we've learned from the famous Mass General studies occurring about 20 years ago, and our own Berkeley girls with ADHD longitudinal study, the BGAL study, show in childhood and adolescence clear impairments, as do boys, and some unique impairments as they develop. So when we started with an NIMH grant back 27 years ago with our BGAL study, we had summer camps. We'd use these for boys for years with ADHD carefully diagnosed and without, get lots of observations, lots of testing done, and then every few years apply for renewed funding to follow them across the developmental span. too many words on this slide. So here's what we've done to date. 140 girls with ADHD, 90 match comparisons, 5-year follow-up basically at the end of middle school, another 5 years, average age of about 20, and then our 4th wave, average age in the mid to late 20s. We're in a 5th wave right now that because of the pandemic, we've had to do online. You'll notice that we've been very fortunate to retain most of the sample because we work at it really hard, and we conducted a really great summer program for the girls and their families when they were younger, and you always treat participants with the utmost respect. In a longitudinal study, if you want to measure change, you don't change the measure, as some of my social science colleagues are fond of saying, but you might need to add measures with development. So starting at our 3rd wave and 4th wave and 5th wave, we have detailed information on the tragic yet all too common symptom domains of self-harm. Non-suicidal self-injury, cutting, burning, mutilating oneself in order to physically express a deep emotional pain that the kid doesn't feel can be talked about, maybe other reasons for this as well, or frank suicide attempts where the intent is to end one's life. We view these as somewhat separate, but a history of severe NSSI in adolescence is a pretty strong predictor of attempted suicide in one's 20s. So don't think of them as totally opposite. They're on a continuum. In our first publication of the wave 3 data, the girls were now about 20 on average, ranging from about 18 to 23. And we asked carefully about engagement in self-harm. Those girls who came into the study when they were girls in our summer camps, who had the combined form of ADHD, lots of impulsivity and hyperactivity and inattention. 23% had made a serious suicide attempt by our 3rd wave, 8% of the purely inattentive, 6% of our comparisons, 6% of typically developing neurotypical girls with an attempted suicide. These are the national averages. This isn't something unique to Northern California. In terms of moderate to severe NSSI, non-suicidal self-injury, over half of the girls with ADHD in the combined form with lots of impulsivity as well as inattention had been engaging in, again, not just pulling or twirling of hair or cuticle picking, moderate to severe NSSI, a little over a quarter of the purely inattentive girls, now young women, and 19% of the comparisons. 19 to 20% of high school girls are engaging in moderate to severe NSSI right now in our country. It's become epidemic, which again would be a whole other talk. But early ADHD, especially early impulsivity, is a key risk factor. In adolescence, and I'm going to go very quickly through these mediational slides. On the left, did you have ADHD as a girl? On the right, how severely were you self-injuring 10 years later? Impulsivity is measured by a neuropsych task called the cancel underline task, and the parent and teachers report of the girls acting out aggressive behavior in middle school helped to explain the severity of NSSI. So keep that in mind. It's the same diagram, but the girls and the parents and the teachers report of her anxiety and depression in mid-adolescence were the strong predictors of attempted suicide when she got older. What about peer relationships? The girls report in middle school or early high school as to how much she was being bullied physically or relationally by her peers was a predictor of the severity of NSSI. But the teachers report of whether the girl had basically been shunned by her peers, excluded from the peer group, was the preferential mediator of attempted suicide. And we can't leave out trauma, maltreatment, physical abuse, sexual abuse, and neglect. Not only were the girls with ADHD in our study more likely to be survivors of maltreatment when they were young, but those with ADHD growing up as a kid, 14% had made an attempted suicide rate overall, cutting across the combined and inattentive groups. But if a girl with ADHD, regardless of subgroup, had also experienced physical abuse, sexual abuse, or neglect, that rate more than doubled to 34%. The liability for ADHD largely lies in one's genes. But if you've experienced trauma on top of that, just as with bipolar disorder, another very heritable genetically based condition, maltreatment in both bipolar disorder and ADHD ups the risk for very serious self-injury. Girls with ADHD don't do as well across time, especially in math, the stereotyped academic endeavor in which girls aren't supposed to do well, although they can if they have opportunities. And by our early adult years, 48% of the girls with ADHD would be classified as math disabled, which is going to give them a hard time with fulfilling many life skills. More time, what did we know back in childhood that could have predicted engagement in NSSI or suicidal behavior? How severe the ADHD symptoms were, interestingly, both impulsivity and inattention, acting out behaviors, negative interactions with dads in the first years of life were even a stronger predictor than negative interactions with moms. We think is a very important potential protective effect if we can turn that around. Poor executive functions, low self-esteem, and beyond maltreatment, adverse childhood experiences. I'm going quite quick. Overall, in our sample and others, girls with ADHD as they grow older don't have as many go into juvenile hall or abuse substances. They may graduate from high school, but then it's really problematic post-secondary with both college, work, and as I've just noted, these terribly high rates of self-harm with some of the predictors I've mentioned. And another finding of real importance, 43% of our ADHD sample had had one or more unplanned pregnancies by the time they were in their late 20s, compared to 10.5%, 11% of our comparisons. This leads to whether the birth came to term or there was an abortion, mental health problems can potentiate with unplanned pregnancies. There's two main treatments that are evidence-based for ADHD as we start to wrap up. Behavioral treatments, reward programs, coordination between home and school, and if you get to be a teenager or adult, CBT, cognitive behavioral treatment, where you bring the contingencies inside your head, anger management, time management, further development of social skills. And then the medications, both the stimulants, kind of a bad name, they actually should be called selective dopamine reuptake inhibitors, SDRIs, enhance the flow of dopamine through the brain circuits that use that neurotransmitter, and a number of non-stimulants that mainly focus on norepinephrine. Both of these are extremely helpful for kids with ADHD if the diagnosis is made well and if the treatments are monitored very carefully. Do girls and women respond differently from boys and men? Not so much to behavioral treatments in CBT, but in the most recent meta-analysis of the world's literature by Koch et al. A couple of years ago, girls may be more prone to side effects from the stimulant meds than are guys, and may be preferentially responsive to the non-stimulants, the alpha-2 antihypertensive meds, and the selective norepinephrine reuptake inhibitors like the atomoxetines of the world. There's a lot of focus, especially coming from the UK and Europe, that treatments for girls ought to involve groups because girls and women, not to just be stereotypic, value social interactions and harmonious relationships so much. And a treatment developed at UCSF by my colleague Linda Pfeiffer called CLASS, Child Life and Attention Skills, was explicitly developed for boys and girls with the inattentive variant of ADHD. And what happens? It's not just timeouts and penalizing disruptive behavior, it's teaching focus, it's teaching organizational skills. And because more girls than boys are going to have this purely inattentive form of ADHD, treatments like this ought to be disseminated more. Here's a very busy slide, but shows something from the big MTA, multimodal treatment study that involved those 579 kids with all those comorbidities we saw a few minutes ago. If you want to get the symptoms of ADHD under good control relatively quickly, medications do quite well if you get the right dose and the right medication and they're well monitored. And adding behavioral family therapy and school consultation doesn't help so much. But if your goal is not only improve ADHD symptoms, but aggressive symptoms, symptoms of anxiety and depression, reading and math scores, social skills, and helping parents get to a more authoritative, calm yet firm style, that dark purple line, lower is better, the biggest improvements came from the combination of evidence-based behavioral and psychosocial treatments and medication. In a very complicated slide that I'll talk you through in 20 seconds, the red line is that combination treatment and the 1/3 of the families who really improved their parenting to be much more authoritative, calm yet firm, firm yet affirming. Those were the 55 kids in the MTA who ended up in the normal range at school in terms of their behavior and academic performance. ADHD has biological roots, but family changes in parenting style can make a big difference for outcome. Finally, stigma. I wrote a book on this topic 15 years ago, need a second edition. I'd like volunteers to help me with that second edition. No, forget I said that. And then I spoke at the AIM summer event 4 years ago on my memoir about our family's very severe mental illness, Another Kind of Madness. Wait a minute, wouldn't stigma, stereotypes, prejudice, and especially discrimination, as Dr. Hinshaw so emphatically emphasizes in his book, which is crucial, wouldn't it pertain to psychotic disorders, bipolar disorder, PTSD? ADHD seems milder, but it's very consistent inconsistency, doing it one trial and not the next, being fine in algebra, not an English lit class, makes people feel you're not trying or that you're just slacking. The overdiagnosis we've been experiencing, especially with boys, also makes people feel parents are just trying to get accommodations. Adults are just trying to get performance meds to play Major League Baseball. But the stigma, I think, is really magnified for girls and for women. Females value social attunement, and that doesn't come easily for girls with ADHD. Everybody knows that girls are supposed to be sharper and more achievement focused than boys these days. What if you're not? There must be something wrong with her or you as a family. So the stigmas can double or triple, and especially with intersectionality if you're a kid of color or a disenfranchised family. So we need to get it right with doing the kinds of assessments that will yield a valid diagnosis of ADHD. Treatments early in life, supplementing in adolescence, academic achievement and self-control and self-esteem seem to be crucial. Girls may be hyperverbal rather than hyperactive. They may be primarily inattentive, so they're not as visible. Girls may slip through the cracks because they and their families compensate for so long. Girls still, to many clinicians, well, it must be anxiety, it must be a conduct problem. If it's ADHD, those additional issues may be salient, but getting families engaged in evidence-based treatment may reduce the extraordinarily high stress that parents of girls with ADHD experience. We talked about this so-called heterotypic continuity. Girls with ADHD are exceptionally liable to self-harm, which is a horrible developmental outcome. We need to work on strengths as well as remediating weaknesses, groups, social skills, enhancing executive functions early in life, bolstering academic achievement may be particularly salient for girls. So I want to thank AIM, funders, everybody I've worked with, you here at today's gathering, and thanks very much.
Thank you, Dr. Hinshaw. That was, okay, let me see if I get this right. Calm yet firm. Firm yet affirming.
Yet affirming.
Yeah, good. I got it. Yeah. Thank you. Thank you so much. And again, we can send questions to Dr. Hinshaw, info@aimymh.org. If you have questions, please send them. And I'm sorry we don't have more time to take questions, but what a great tool. What very practical.